Welcome to the Health Pod with Lamelle Research Laboratories, where we like to talk on all things health. I am joined by Dr. Mpume Zenda today, once again. And today the conversation is going to be a little bit more interesting. But first, let me introduce Dr. Zenda. She is known as Dr. Zenda to most of us. She's also on her social media pages. She's known as Dr. Gynae. So please go and follow her there. She is an advocate for good, healthy sex, consensual sex, and that's what we're talking about today. Yeah. She does have a gynae practice. She is well trained as a sexologist as well. She's written one book, and there's a second book on the way that we're very, very excited about. But let's just fall right into it and let's have a conversation about sex.
Let's talk about sex, baby. Yeah. Thank you so much for having me.
It's
always
pleasure.
Fun. It's always, just so comfortable as well. And I like that.
I think today we have to break a little bit of the stigma associated with sex. And we're talking about an interesting thing called FSD. So what is FSD?
Why do we keep just calling it FSD? It's just female sexual dysfunction. Sometimes when we talk about when we use sort of those words, it kind of sometimes cuts people who have no idea what it is.
I have that. What? Why would I want that? No. I'm okay. I'm healthy.
Right. So when we talk about female sexual dysfunction, it's actually more just a big umbrella, and there's multiple things that fall under there. And the way I like to explain it is, that idea when people say, oh no, I had 1 round or 2 rounds. The sexual cycle. That's the best way in terms of looking, particularly for clinicians, if you're wondering where exactly to look at. So how female sexual dysfunctions are divided, it's based on, now we have from the DSM-5. First and foremost, we've got a desire and arousal. Before it used to kind of be separated, but now it's kind of joined together. So desire and arousal. Desire is, I'm thinking I want, or I feel like I want. Arousal it's sort of 2 parts in the sense that it is a physiological sort of manifestation of that desire. So coming through in either lubrication, you also get physiological changes in terms of your heart rate, your blood pressure going up a bit. Then we look at things.
So could you compare it to, I see a piece of cake. I like what it looks like.
I like what it looks like.
My mouth starts watering.
I
want the cake.
I want the cake.
I have a desire for the cake.
Yes.
Just seeing a nice cake doesn't mean I'm desiring it.
Yes,
and
absolutely.
The same thing with sexuality.
100%.
I'm seeing something I like. And my body tells me I'm desiring it. Fabulous.
100%. You got that one spot on. So that's desire and arousal. Then you get orgasmic disorders, which is basically orgasmic dysfunction, people who struggle to have an orgasm or have an orgasm that is not, or that has changed, is not as it used to be in terms of intensity. Then you get pain disorders. Before we used to have sort of the dyspareunias, the vulvodynias sort of separated. Now we've got what you call pelvic or vaginopelvic pain syndromes, and that's where they all fall in. So any kind of pain, we can even kind of divide it into, is it superficial in that generally it's around the entrance, or is it deep pain or deep dyspareunia? And then so we mentioned desire, arousal, orgasm, and pain. Those are the things. And arousal, again, like I said, it really does very often in terms of how it like that mouth watering. We look at things like lubrication, for example. Now, to say something is a dysfunction versus a sexual challenge, all of us at any point in our lives will go through some kind of a sexual challenge. But for it to be, or to qualify as a dysfunction, first and foremost, it has to bother the person. If a person is unbothered, it is not a problem. There is nothing to fix. If it's not broken, don't fix it. Secondly, we wanted the symptoms to be present at least for 75% of the time over a period of about 6 months. Although there is a sort of like a revisor that, I've seen quite a number of times when it comes to pain. Please don't wait for 6 months experiencing pain before you go and get
So
help.
1 or 2 discomfort, uncomfortable sexual interactions should actually, because that might be something physical.
Yeah. Absolutely.
You might actually have
an underlying
disease,
gynecological condition. So please don't wait for 6 months to say, okay, now I'm going to go to see a gynae, a sexologist, or a healthcare professional.
And this is specifically in females that we're looking at now.
Yes.
And of course, females are a little bit more complicated than men.
Complicated?
So when I'm talking about female sexuality, I talk about the fact that with guys, you can go, hey, honey. And he can go, I'm having a shower.
Microwaves.
I'm ready.
Microwaves.
While with me, it has to be on a night where I haven't had too hard a day.
Yeah.
We have to plan it.
Yeah.
The dishes need to be washed. The kids need to be in bed. I have to have enough food, but not be over full or hungry. I need to have 1 glass of wine, not
too much.
Taking a shower. It needs to be quiet, So it's a little bit more. It's not
we are like coal stoves. We need a little bit of like.
We need a little bit.
You can't fry that meat until the coals are red.
Yeah, you can't also put the charcoal in and just gooi the lighter in. You have to pack the kindling.
Everything has to be right.
Yes.
And this is actually funny enough. I love that. I think it was an article that I wrote at some point. And I said that, funny enough, when you're looking particularly in heterosexual relationships, the misunderstanding between the wiring between males and females is very often where a lot of our sexual challenges come from. Because if he's like, yo, no, this foreplay thing is taking too long, and you're like, well, nothing is going inside anything until I am nice and hot. And then suddenly there's a little bit of tension. It plays into things like sexual desire discrepancy. So when we're looking at desire discrepancy, that speaks of a couple where there is a mismatch in the number of times or the frequency we want to engage in sexual intimacy. And they often say the low desire person actually is the one who controls the sexual narrative within the relationship, because the other one kind of always wants, but
they're always ready.
They need the consent of the other one to have. So the one who's always saying no. And so this becomes really important because, of course, yes, there is, self pleasure, things you can do on your own, but particularly in a relationship, sexual tension can really cause, or sexual issues can really cause a relationship to be uncomfortable. And you add on the whole concept that we still struggle to have communication or communicate and have frank conversations, open conversations about how we feel. You'll find somebody just wearing a onesie and you're like, hey, and then what happened? And meanwhile, they're just angry at you and they're like, you're not getting any. And, so those are the things we see with couples. And it really does become important for us to look at these sexual challenges or dysfunctions, recognize them, and also know that there's professional help out there for people when there are issues.
So there's a lot in there. There's a lot of unpacking to do because it's about me and my partner having the conversations. It's about, we're joking and we're laughing now, but it's also about the conversations with your friends, because how do I know what's normal and what's abnormal? We have this conversation with our children and our, when we were speaking about it the other days, when do you learn as a married person what is normal? We don't have the grannies and the mothers around that go, yes, you should, or no, honey, just put out. It'll be okay.
It'll be okay, yeah.
My mother always used to say, grin and bear it, bite on a stick, because I don't know what's normal, because nobody's ever had this conversation. So there's the normality in conversation.
Yes.
There's the normality in sexual interaction. What is taboo and what is not? It becomes so complicated.
It does.
Because just that could shut down, let alone the fact that you want to shut down because this is not a conversation that I'm comfortable with.
Yeah.
So how do we break those taboos?
Look, it's layers, and the reality is it's gonna take a couple more years of having these kind of conversations before everybody starts kind of getting comfortable with, first and foremost, with themselves. You mentioned something really important. Parents often ask me, so when should I start talking to my child about sex? And I'm like, don't worry about sex yet. Get into the habit as early as possible to talk to your child about everything and anything, and also be okay with things that you're not sure about. You don't know. Look them up together. No, nobody is supposed to be knowing all these things, because what it then does is, the key thing to these conversations is safe spaces. When I know that I can come to my mom about anything, Mom, guess what? I had my period. A lot of parents, my mom was a midwife, and shame, I tell this story all the time, and I'm like, Mom, it's nothing against you, but it's just to show that just because a parent is older doesn't mean they know. Just because they've got the content as well doesn't mean they're able to explain it to you. My mom was a midwife, and because of the cultural norms that she had grown up with, it was still difficult for her to give me the information. So it's easier to start your kids with talking about things like your body changing, like your periods. That's it's really difficult for other parents, but that's better than going for the kill.
Going directly into birds and bees, yeah.
Right. And you want to build that rapport. And I always say our children also give us so much room in the way that they ask questions, especially the Gen Zs of today. Like, they ask a lot of questions, and sometimes parents cage in because they're unsure of their own information, because it's their own taboos, and so they create a barrier. Please don't. Find credible information, go through it with your child, and it's okay to be like, actually, I have no idea. My mother didn't talk to me about that. What that does is you're also instilling a sense of confidence to advocate for yourself in the sexual space, because the ripple effect of all these things as well comes in with things like how we negotiate consent with our partners. The grin and bear, a lot of girls grin and bear in pain and just be like, just finish. But then we've kind of sort of self-betrayed our own sexual pleasure, our own voice in that space. And so that's why I think sexual intimacy conversations can never just be about what went inside what, or what pill you took. And no, it's so much more. It's the communication, it's the safe space, it's the consent, it's am I feeling okay about it today? And I always say, guys, talking about sex, or even sex in itself in terms of the act, it's awkward until it's not. But you have to lean into that discomfort and vulnerability until you kind of hit that sweet spot, and suddenly
it is a comfortable conversation to have. Yes.
Oh, it's a tsunami.
And it's also a tsunami. Just all, it all happens together, and that is so important. Is the fact that it works together,
100%.
And that there is this interaction, and that it is about sharing what I know and what you know, what I experience and what you experience. And I think also the as you said, it's not just the female sexual dysfunction. It's not just about where am I feeling comfortable or uncomfortable, but it's my ability to have the conversation with my husband or my lover to say, my body's changed. I'm not lubricating as well as I used to. So, honey, I'm buying lubricant not because I'm having an affair with someone else and because I cannot get wet for you. It's my body. So that has to change. And you know, that and it might be a little thing.
I mean, you say something really important. So when you look at, for example, guys have a bit more of like, sort of like a linear, I mean, they will get their sort of like kick between like 6 a.m. to 8 a.m. of that high in testosterone, but they kind of like that, you know, pretty much every day. Of course, we know that with as they get older, the testosterone, they also do kind of
dips just a little.
Well, it does dip. But when you say something about females being a bit more complex, and I agree with you. We change on a day-to-day because we are cyclical beings. Just on a monthly cycle alone, you could want different kinds of sexual intimacy at different times. Find people who are not comfortable with having sexual intimacy during period, for example, it's stay away during that time. And very often they're uncomfortable to do that, as in to be intimate around that time. Then you kind of gradually move into your day 15, your ovulation, where your peak testosterone and estrogen are at their peak. And we kind of want to be on top of everything. Our work, our guys, everything, everybody. We want to be on top. And it's nice. And guys generally will enjoy when we are at our peak. But very often we struggle to communicate when we then, after that ovulation, you first of all, you increase your progesterone, which may, for some people, kind of make you feel a little bit almost like depressive, moody or so. But then what happens is all the hormones literally drop to the floor. And this includes ladies who may be on, for example, contraceptives, particularly the pill. And that's what happens with those last few pills. It's like, why do I get like a slap in my face, mood-wise around that time? That premenstrual phase, tender breasts. So what was nice a week or 2 weeks back, today's like,
no, don't.
I don't want. And then today, like, you want to be on top? It's like, no, just cuddle today. Just,
feed me chocolates and hug me.
Exactly. Exactly. So when we can understand just how we are changing over just on a cycle to cycle, first and foremost, and then you get the different phases. I mean, we all kind of, I hope, learn, our first and glorious days of sexual intimacy in our 20s, maybe some people a little younger, maybe some a little bit older. But around that time, we're like at our peak fertility. Our hormones are fluffy. Everything is, looking good.
Our bodies are great.
Great.
We can do anything.
We can do anything. We are in bikinis. Then we have babies. Then we get a little bit older. Suddenly, other things start to factor in. Postpartum, for example, that is a major one in terms of how it affects our sexual function. All of those nice hormones are right at the bottom because, especially if you're breastfeeding, prolactin is sky high to make sure that you are producing milk and stuff. So it's stopped being the guy's milk, it's the guy's food now.
It's baby food only,
right?
Yes. Yeah.
But we never think about how does that make a woman feel. That sometimes kind of messes with your mind. It's like, this feels a
do I hate him now? No, honey, you're just making milk.
And for a lot of women, it may take anything from 6 to a year before they really come back to themselves after having a baby. So those are important phases of a woman that they go through that we should be aware of in terms of their sexual function.
And if we didn't talk about that, we wouldn't know that.
Exactly.
So it's like, is it normal for me not wanting to have sex after I've had this little baby? I'm fully recovered. Somebody told me one day, she said no, she told her husband that for 6 months after she's had the baby, she'll unfortunately not be having sex with him. I'm like,
my only advice though.
That's tough on him, hey?
It is.
But you can't do that to him.
No, you can't do that.
So I think she said it jokingly.
Okay.
But, then we also go, but are you...
It happens.
Of course it happens.
My couch, my pink couch, it happens a lot.
Yeah, you don't want to have another baby. You're breastfeeding. You're adjusting to a new lifestyle. And I think that's also challenging, is the fact that our hormones are fluctuating.
But also
inside a space where we're superwoman. We've got jobs, we've got homes. I'm in the position where I've got grandchildren and parents in my environment that I'm all looking after. And then my kids are around. It's a lot. I'm giving a lot. So, it's... those conversations become so important.
And that's why, I mean, things like postpartum depression has become such a big thing. It's become, I mean, in terms of the number of people that we see. And a lot of the times it's, yes, we know that there is that hormonal, that scientific background to it. But a lot of the times the overwhelm comes from all the other pressures, and so everything has to be done We are a couple. Let's share the responsibilities, speak out. And in fact, that superwoman mentality, that bounce back after delivery mentality, please guys, no.
Yeah. Give yourself a little bit of time. Ask him to give you a little bit of time as well.
Get as much help and stuff. And then, you get the other hormonal issues. Previously, we spoke about things like polycystic ovarian syndrome. Things like endometriosis in particular is very much has a huge impact because it causes a lot of sexual pain, deep sexual pain or deep dyspareunia. Then you hit things like other hormonal things like menopause, perimenopause. I mean, that one is probably one of the frustrating ones where you find people almost resigning themselves to, you know what, I'm old now, I'm not going to get involved. It also really, for me, has been about conversations that help us change our attitude towards who's supposed to be having sex, who's supposed to be having pleasure. We're always like, it's him, it's them, it's the young ones, it's the sexy ones. It's like, no, babe, it's you.
Yeah.
Right? And when you can take that ownership for your own sexual pleasure and say, this is important to me, so that when things kind of move sideways, you're kind of like, something has gone wrong. I need to get that sorted out. And just, again, we spoke about just the understanding between couples. Explain to your partner what feels good to you. What used to feel good to you in your 20-year-old body may not necessarily feel as good when, in your 40s, in your 50s. You might be focusing more. Maybe you used to enjoy 2-3 rounds at a time. 40, 50, you're like, you know what? I'll stick with quality over quantity.
Monday, Wednesdays, alternate Sundays.
You must keep on defining what sexual pleasure is for you, but always hold it sacred. And when things are not going right, please go and see a professional.
So I think the big thing is, when we're looking at female sexual dysfunction, we need to know that there will be fluctuations. And those fluctuations are normal.
Yes.
They can be cyclical. They can be related to life.
Yes.
If you are having a challenge that is bothering you for more than 6 months, not pain, maybe it's time to come and seek medical advice.
Absolutely.
Find a sexologist that can help you.
Don't be embarrassed.
Or a person who's got a sexually trained background. Because just going to your GP... I'm visualizing a GP that I would never go to with this, then it does become a door handle conversation as you walk out quickly, So we have those 3 groups of areas. What are the treatments for female? What do we look at treatment wise? Is it therapy? Is it sex therapy? Do I have to schlep him with me every time?
So it really does depend on the symptoms. So, for example, if we're looking at desire or hypoactive or low libido sex drive, that can be, again, this is also what makes it difficult. There can be so many reasons why it's happening. It could be, like we spoke about, the different changes in terms of hormones, in terms of phases. It could be an underlying medical condition. It could be medical treatments, things like antidepressants. Some hypertensive medication can cause that. It could be a difficult relationship, or things are not going well within the relationship. If there's one thing about women, is that sex really does start in our brains, not just like biochemically, but also in the way that we think. You mentioned it. If I'm worrying about my dog, my child, my this, my that, the fact that you didn't open the door for me, you forgot my birthday, and by the time we go to bed, I'm like, nah, onesie vibes, So it's all those things, and being able to pinpoint what exactly is the root cause, and then you target that. There's always room for therapy. I always say there's always room for medical medication. When you look at the woman who's menopause, for example, hormone replacement therapy is a big one, and it really makes a big difference. I always just say hormone replacement therapy. Everybody thinks estrogen, and I'm like, plus testosterone, please, right? A lot of women, we find that they've got a very a decreased testosterone,
and that would definitely take away your sex drive. That takes away all your drives.
It takes all your drives, your energy, your exercise drive,
getting out of bed.
You're
getting out of bed hormone.
You're getting out of bed hormone. In fact, when you think about, when you look at, I mean, men have got about 10 to 20 times more than we do. I mean, when guys just like, let's go. I'm like, where do you get all this energy? Give me some of your testosterone, please. Right. But we don't have as much, and just a little bit, just replacing it. The nice thing is that it has been approved, particularly for the postmenopausal, for the menopausal women. In women who have not yet menopause, there are other remedies, medication that we can use, some better than others, and then some practical things as well. Just good old lube. Use a lot of lube, particularly if you're experiencing pain, poor lubrication during intimacy. That becomes really important. Things like anorgasmia or orgasmic disorders in particular, very often we find that there could be nerve-related things, but a lot of the times you find that it's psychological issues as well. Past traumas, and very often we think past traumas have to be some drastic big thing, like, I was molested or an assault. Not necessarily. Somebody who tries to put on a tampon for the first time and they put it on wrong could make them actually tip into vaginismus if that causes them. Somebody who has a very uncomfortable first sexual encounter, or first sexual debut, a guy doesn't know maybe what they're doing and stuff. They're fiddling around. They kind of like don't wait for the foreplay. They know that they just go in. That could make somebody sort of like have an aversion towards. So it really does become important. I think particularly for us as clinicians, talk to your patients. Take the time, find out where are the areas. And a lot of the times it's just sometimes things like religious backgrounds, cultural backgrounds, and we're so scared because we don't know, because nobody has ever said it's okay.
And I think in our culture, we don't only have 11 languages, we have multiple cultures, and all of us have our little taboos and our habits and things that we are allowed to and not allowed to do.
Yes.
And that also becomes important in the relationship, is to have a conversation about that.
What feels okay to you. I once had somebody say, my guy was like, no, let's bath together. And I was just like, what? It's like, my parents used to bath together, and it's just a bonding time. And she was like, no, never, we're not. And suddenly, like, it's just the way that we are socialized. And just layering it, particularly between couples, a lot of grace, a lot of respect, a lot of safe space for one another.
Yeah, and it helps if you love the person as well.
Please do. No, be a friend. Love sometimes.
Be friends, yes.
Be good friends, because even when you don't feel like, and I want to say, even when you don't feel like it, if you like the person, I'll be like, your hands and mouth work just fine.
Yeah, so fabulous. And then, of course, there is also, we always have to mention our supplement.
Oh, yes.
So I think the supplement definitely does. So we've got the Lady Prelox. Yeah. That's an antioxidant. Yeah. It helps with blood flow. Yes. It's natural. It's not going to change your hormones. Yeah. So I think that's a good base to start with. But once again, if it doesn't improve, we need to seek medical advice.
Absolutely.
Thank you. And thank you.
This was so nice. We could keep going.
We could definitely keep going. We could do a 3 or 4 hour conversation on sex and sexuality. And I love the fact that it is open, but it's also serious. And I do think that, I hope that you've gotten some advice and some confidence that you're not alone. I think that's a big conversation that also needs to happen. And that your normal is normal.
Yeah.
And if you need help, please seek medical advice. If you have questions, please put them into the notes below this. Please join us on our social media pages as well with questions. We can always forward questions to Dr. Zenda, and we can answer them. And of course, Dr. Zenda has her own gynae practice as well. Thank you very much for joining Health Pod Talks today with Lamelle Pharmaceutical. And please join us again, like and subscribe, and add any comments. We love to hear your comments on this conversation.
Thank you, ma'am.
Thank you.